hold on a second. Pause that. I have too many things open. We're on therapy. And I want to see, where did my clicker go? Start that. Bracelet keeps getting in my way. That. So looking at therapies is a really good continuation of your study from psychological disorders. And if you do find this interesting, if you found last week's readings interesting and you felt yourself searching, looking, asking more questions and kind of going, oh, this is something that's really fascinating to me. Abnormal psychology is offered every quarter. Whoever teaches it, I'll probably be teaching it this summer, but a number of different instructors here teach it. And every week cover a different sort of category of psych disorders. And within that, we're always also covering the therapies that are used in that specific, range of disorders and all the different theoretical perspectives that go along with that. But kind of looking back at what I introduced last week in the views of psych disorders and being insane, right? That's a negative term, and that's not something that we use today. But the history of insane treatment was not very nice. This idea of having to contain people or do things to them because they were possessed by some kind of demon, or they'd have to drill a hole in their head to let the evil spirit escape. Philippe Pinel recognized that this was not, how we should be treating other people. Even though we don't understand what's going on with them, we can't treat them that way. So he had this thing called moral treatment, where they'll still have people in facilities, but at least we'll treat them with some empathy, right? Treat them with a little compassion and dignity. And then Dorothea Dix was in the United States and in Canada, and went to Scotland, and she founded these different institutions where people could go and be cared for. So they weren't being cured. They didn't have treatments that for everyone that allowed them to be integrated into mainstream society, but at least they were treated with some compassion. Now, some of the treatments, the medical treatments that were done, might seem a little bit inhumane to us today. If you watch old footage or you look at some of the old pictures, people do look like they're kind of being like wrapped up. Like there's actually like a compression therapy where they would wrap a person up really tightly, or they put them in a hot box, and like kind of like the idea was probably coming from that same notion of like sweating out the demon or sweating out, or and so it's maybe not the most logical thing. However, you will see some of those treatments even being done today in a sense like compression therapy or heat therapy. Sometimes people do go through that, either to jolt their nervous system or for pain management, depending on what other things are going on. But we're not putting people in straitjackets and in padded rooms, right? Electric convulsive therapy, shock therapy, would have been something that you would have seen in the late 19th, early 20th century, all the way through the 1950s. But it was used quite differently than it's used today. It was used more in the light of punishment or aversion therapy. And really, electric convulsive therapy today is used for extreme depression. And it's used more often than I think that we all realize. And some people, it's controversial, clearly. You're putting a current of electricity through a person's brain. So that's controversial in and of itself, right? But some people have said it's saved their life. their thinking, they had no activity in their frontal lobe, they were so suicidal, and then after going through ECT, they could see the light again. They were like, oh my gosh, I can't believe that was me. So we'll talk about all these different types of therapy. We'll introduce psychotherapy today. So psychotherapy is a broad term for lots of different types of therapy that fall underneath it. It's essentially some kind of talk therapy, some kind of management, but we're really treating the mind. We're not doing anything to the body. So under that you have psychoanalysis, and we'll talk about Freud and his influence there. Behavior therapies, which stem largely from learning theory. We're really looking at all our concepts from classical conditioning and operant conditioning are the basis to behavioral therapies. Cognitive therapies, where we're now changing the way, trying to get a person to change their way of thinking, because the underlying idea behind cognitive therapy is that it's your disruptive or irrational thinking that's causing the dysfunction. So change the thinking, then that will change the behavior and create functioning. And then, of course, we have combinations of cognitive behavioral therapy. Humanistic therapies, we've got two main contributors to humanistic psychology, right? Who are they? Carl Rogers and Abraham Maslow. Good. You're getting good review for the final exam. Our contributor here as far as therapy goes was Carl Rogers. So we'll talk about him. And a lot of the ideas from Rogers go right into group therapy. Certainly you can use different methods of cognitive therapy or psychoanalysis in group therapy, but humanistic probably is the most direct contributor to group therapy. And then in our next class, that's when we'll spend time talking about biomedical therapies. And primarily here, we're talking about medications. Okay, so we call them psychotropic medications. Some of them are going to sound familiar to you because we've studied them before when we were talking about psychoactive substances. Some of those were prescription drugs. And then some are going to be new, and we're going to kind of try to keep them up to just basic categories. I don't expect you to memorize a huge list of drug names, right? We're not in a psychopharmacology class, right? And then other medical treatments. So I already mentioned elective convulsive therapy. There's also deep brain stimulation. Boy, you better have tried everything else first before you let somebody put a probe into your brain, right? Let's try every single absolute form of therapy, every single medication combination before you allow someone to drill a hole in your head and stick a probe in there, right? It should not be taken lightly. Same thing with ECT, right? It's sort of a last-ditch effort, for therapy. But there's other simple medical treatments that you might not have thought of, like light therapy. Light therapy would be considered a medical treatment because you're not going in and you're not talking to a therapist about, your problems or your, different things that you're facing and stressors and things like that. You're literally you buy a light, a happy light, and you put that in your room, put it on your desk. Clinical trials have shown, they've compared people who have no therapy at all. So everybody has a baseline, right? You all suffer from seasonal affective disorder or depression. So you have a control group, they get no treatment. You have a placebo group, they give them a little contraption that they tell them is some kind of magnetic electric energy or something. They give them a lie, and it's really nothing, right? It's just an empty box, but they tell you that it's going to do this thing to help your mood. And then they give the third group the light. Well, they are exposed to this for a certain amount of weeks, measure them on their levels of depression again. They find that the people who had the placebo, who had the little fake contraption, actually did improve in their mood a little bit. So the power of thinking that something is helping you, keep that in mind with all of these things in therapy. But then there was a clear statistical difference in the people who had the light box, that their moods improved significantly. And we know that light, is going to suppress melatonin and make you and increase serotonin. And so you've got your sleep-wake cycles activated, and that can improve mood. So it falls in line with brain science. Some of these other so-called medical therapies, you have to be really cautious of. When you hear these advertisements on TV, or there's somebody out at the mall trying to sell you some kind of energy band bracelet or magnet therapy that's going to get rid of all of your problems or make you a better athlete, ask about the science. What's the clinical trials? Have they done a clinical trial like the light box? And I'll tell you right now that those bracelets that they're trying to sell at the mall have no science behind them. In fact, there's a trick that the person selling it knows to push you over or to make you stand up straight when you put the bracelet on. It's a scam. So in all of these types of things, that's where you use your scientific mind and you go, where's the evidence? How do we know this works? And that kind of comes back to all of the therapies. How do we know all these people are in therapy? How do we know which ones work? And then why they work? And we'll kind of get to that probably in our next class. But let's get some basics under here. Who can prescribe medications? Three, two, one. Let's see what you guys think here. Okay, so a little bit mixed. All right, so a clinical psychologist. What kind of education does a clinical psychologist receive? What are the letters behind their name when they graduate, after they've finished their schooling? Come on. PhD. Thanks, Kristen. PhD. There's some other possibilities. PsyD. Good. See, now you just had to think about it a little bit. The one that I have is a little gray area because it's usually not going to be clinical psychology. Depends on what university the person went to and if their program has an endorsement that allows you then to have clinical hours so that you can get your license. And that's an EDD. Uh-oh, my pen is running out. I mean, there's other doctorates, but these are academic doctorates. All right, so they're terminal degrees. It's the highest you can go in that particular field. So a PhD is a doctor of philosophy, but then clinical psychologists, then they're majoring in clinical psychology, right? But that PhD is sort of a big umbrella covering all the liberal arts and natural sciences. Sorry. A PsyD is a doctor of psychology. So sometimes people, if they know they want to be therapists, they want to be clinical psychologists, and they're looking at programs and they're going, well, what's the difference between a PhD in clinical psychology and a PsyD? The PsyD is a little bit more applied. I mean, people with a PsyD are really going to go out and be counselors. They are going to be therapists. Whereas a PhD in psychology, you may go more the academic route. You may be a researcher. Even if you totally study clinical psychology, you may end up being more on the research and academic side of it, the science side of it, and less so the practitioner, the person actually working with clients. But if you have the eligibility to do your internship where you're getting supervised with your clinical hours, then you can become a licensed psychologist. So often people will want to do the PhD track because it's probably more academically rigorous, and then they have more options. So they can get a job as, say, a professor or a researcher, and then if they're licensed, they can have a practice on the side, or they can take clients and do that as part of, you know, another aspect of their job. I've had friends that have done that track and didn't get licensed right away. So they graduated, they had the PhD, and did the internship where they had all those supervised clinical hours, but didn't sit for their exam for whatever reason. Often it's because they got a job somewhere that didn't require licensing. Well, but then, just like a lot of things, time passes, you lose your hours, don't count anymore. And so then they have to backpedal and either retake courses or refigure things out. So, and then they go, geez, I should have gotten licensed right away. Why did I wait? I shouldn't have waited. So if you're going to go that path, it's kind of like, well, see it through. And then this is going to be more, you know, really directed towards education, right? An EDD is a doctor of education. So I never had a clinical pathway in sight. That was not my goal. That was not my intention. Now, what if you want to be, you know, a counselor, but you're like, I don't know if I want to go to school for that long, or do I really need to go to school for that long? Well, you know, you can get a master's degree, an MA, Master of Arts, or a Master of Science, or there's a Master of Social Work or a Master of Public Health. I mean, there's a lot of different master's degrees that can make you eligible for supervised clinical hours and licensing. So there's lots of different license options out there. So you can be a counselor, you can be a therapist, and not have to have a terminal degree. You know, so there are different, you know, career options, because sometimes, you know, you guys are young and you're like, if this is a field that you're interested in going into, it seems really daunting to look at something that, oh my gosh, I'm going to be in school for another 10 years before I even actually ever get paid. Then, you know, there are other pathways. Okay, so can these people write prescriptions? No. In general, no. Not just on its own, right? You get an academic doctorate, it's just that, it's an academic doctorate. Even if you get licensed as a psychologist to conduct therapy and you're billing insurance, that doesn't mean that you can write prescriptions. What do you need to be able to write a prescription? What kind of degree? MD, medical doctor. There's also, you know, other people that can write prescriptions are nurse practitioners, nurse practitioners, ARNP, a physician's assistant, so these are like master's degrees, right? So there's different levels in medicine that you can train for and have. You probably have more limited amounts of prescriptions that you can write. A DO is a doctor of osteopath that has almost as many privileges as a MD. But then if you're really going to be working with psychiatric patients, then you need additional training in psychology, and then you're a psychiatrist. But that doesn't mean that these people with these credentials and these licenses can't prescribe psychotropic medications. They can. So that's always a question when you're going into, you know, meet with a doctor. You know, are they managing your whole care? Are they just writing you a prescription and then you don't see that person again for a year? That's like, we'll kind of keep that in the back of our mind when we get to that topic next class. But actually, our correct answer here on our slide is E, B and C. There are times that you could have a master's degree, clinical training, you know, or the doctorate, and get special endorsement to write a limited amount of prescriptions. These are basically in cases where there's a need. There's a high demand for people to be able to prescribe these types of medications, and there just simply are not enough psychiatrists. So, for example, the state of New Mexico allows this. It's a state that has a lot of rural areas. Hospitals are spread way far apart, and lots of people in need of psychiatric care. And so you can get a special endorsement. I think another state is Kentucky. I want to say it's either Kentucky or Louisiana. I can't remember. Another special case is the U.S. military when you're abroad. So overseas on U.S. military bases, they may, allow someone to have a special certification licensing. Obviously, they have to take some additional coursework and get permission to do that because they just don't have enough psychiatrists. I mean, if you're working a military base overseas, what's the likelihood of there being those specialty physicians to treat people? Okay, so a few people got it right. Okay, and definitely psychiatrists we know. Okay, so so the clinical psychologists then have a PhD or PsyD and occasionally some other form of doctorate, but they've really got lots of expertise in research and therapy, and then they've actually gone through those clinical hours and sat for the licensing exam. A psychiatrist then has a medical degree in addition to a residency in psychiatry. Anytime a person graduates from medical school, then they have the MD behind their name, but you have to do a residency after that, and people will choose what their pathway is going to be, and a lot of people will choose a specialty, although, boy, we need family practice and general practice doctors in this country more than anything. But people will often choose a specialty, and then that's more years in your residency. It's not uncommon for someone to go a pathway where they get a bachelor's degree in psychology, go straight to med school. So then that means that during their bachelor's years they were taking all their natural science classes. Then they'll go to med school and then decide to focus on psychiatry. But if that seems like a really long, far-out plan, but you are interested in working with people and helping people, there are other routes. You probably are going to need a master's degree. I have not really heard of someone at a bachelor's level working at a high-level one-on-one counseling type job. You could maybe, after a bachelor's degree, get special certification, like for substance abuse counseling. Sometimes years of experience can allow you to sit for some of those certificate exams, but it's going to probably be at least something beyond a bachelor's degree. Even being a counselor in a high school, you often have to have a master's degree. But I told this to my class yesterday. There are a couple areas in psychology, in counseling, in research that we just don't have enough people going into. Like the wait lists are so long. One, of course, is geriatrics, because we have an aging population. We're having, by the year 2030, we're going to have more people over the age of 65 than are people under the age of 15. And by, I think it's 2050, we're going to have more people over the age of 80 than people under the age of 15, and that's globally. So we need people to go into geriatrics, and whether it be medicine or psychological care, counseling. But then the other big field is autism. If you want to work with doing research on a disorder, that's the one to pick. There's just so many unanswered questions. And then if you want to be a therapist, you got to like children, okay? But and you got to be able to deal with a lot of unpredictable behavior. But there was a guest speaker that I went to last week from Children's Hospital, and she works at the she's a clinical psychologists at Children's Hospital and the UW Autism Center, and their wait list is a year long. And it's not because they don't have spaces to bring these children in, it's because they don't have enough therapists. So they're hiring left and right. I mean, so if you're interested in that kind of work, that's a good choice for your career path. But again, you have to like children. Okay, so have any of you ever been to therapy or counseling? Okay, stop there. All right, so only a few people, 2 people see both a psychologist and a psychiatrist, 6 people in the past. Not as diverse. A class yesterday, of course the class yesterday was bigger, but we had a lot more people up here in this category. Do you currently know anyone going to therapy? You're like, well, 6 people in this class are, or however many, well, no, 2 people in this class are. You're like, so that might be the person sitting next to you. You have no idea, right? Okay, so that's kind of the not sure. You're like, maybe, how do you know, right? But certainly a higher percentage. What kind of therapy do you or someone you know, or the people that had gone in the past, you can also answer. And this, even if you know someone going to therapy, you might not know. Three, 2, 1. All right, so psychotherapy, some behavioral therapy, one person hypnosis or meditation, and then combination, right? So let me ask you this. Do you have to have a psych disorder to go to therapy? No. Once you go to therapy, are you destined to be in therapy the rest of your life? No. Okay, so the view of therapy has changed dramatically in recent years. It used to be thought that only people who are mentally ill go to therapy, no one else goes to therapy. Or it has to be a lifelong process. And that is no longer the view of therapy or of psychotherapy. However, psychoanalysis, which is, again, just one type of psychotherapy, was founded by Sigmund Freud, and he did think it needed to be a very deep and long process. In fact, a lifelong process. That was his thought on the subject. He was, talking about the unconscious, right? The reason why people have dysfunction, the reason why they have irrational thinking, and then this sort of irrational behavior, which he said was that manifestation of defense mechanisms when people are doing things unknowingly that are hurtful to others or to themselves, self-deprecating type of behaviors. He said that's because it's buried in the unconscious. You have so much anxiety that's shoving that down. We need to open the window and let it out so that you can then come to terms with it. And he said this was a very deep and rigorous and hard process that we have to spend a long time going through. So Freud's views of psychoanalysis have changed, or our view of psychoanalysis has changed considerably since Freud's time. It's decreased in the same way that he used it. It's decreased rapidly. However, a lot of his ideas have carried on through contemporary psychologists. They will use even some of these methods in their own way, in a different way. And a lot of people still claim that talking and getting you to kind of realize those things, all those little denial things that people do, you got to recognize it. Once you recognize what you're doing, then you can move forward. So a lot of people really still believe that that it's hugely important that you are going through this process of revealing, you know, what is all that stuff and why are we, what's the baggage and how are we going to unpack the baggage without, you know, it being too harmful to you. So, but Freud did have some techniques here that come a lot from that theory of personality, and then he applied it in the therapeutic setting. He did have the patient lay on a couch. His Chase Lounge, I believe, is at the Smithsonian, or it might be in London. It was at a museum in London, or it travels around. But it really is his couch, and he really did have the patient lay down on the couch. That's not a myth, and he would sit behind them because he felt that if they were looking at him, he could be maybe too much of an influence. So he wanted them to sit, he wanted them to be laying down and relaxed and not looking at him. He did something called free association, where they would just say whatever readily came to mind. Just have a free flow of ideas, thoughts, and just talk. He would try to not interrupt very often, so those long moments of silence to try to just get the person to keep talking. He said what that's going to do is it's eventually going to start opening up things and reveal things that are in the unconscious. You guys might have played a free association game, like, you know, on long car trips, and you'd play some kind of, you know, you'd see something or you'd say a word and then somebody else would say the next word that comes to mind, and or you'd go through the alphabet and you'd have a, let's do animals, okay, A, aardvark, B, bird, C. Okay, so like that. All right, yeah, bird and cat. Good ones, guys. Okay, just kidding. Okay, let's analyze that, right? Okay, but that's free association. Of course, he's going to try to go deeper, right? Okay, resistance. He said that as the person is talking and as these things are kind of bubbling to the surface and coming to awareness, there's going to be pain, right? If there's a reason why you've pushed it into your unconscious because it was upsetting or anxiety-provoking, so as it comes to light, you may resist it. So you're going to be, you know, continued denial, right? So he's got to do different techniques to kind of combat that natural resistance that's going to occur. And so then he would use dream analysis to try to help people to think about things, and maybe the dream could reveal some meaning from your unconscious. And we talked about that briefly with the latent content and the manifest content, and there really was a lot of symbolism, and he had very figurative, you know, meanings to things that you would dream about. You know, I mean, maybe your dream has some symbolism in it and has some meaning in it, and there are definitely a lot of psychologists out there today that use dream analysis. However, I would caution anyone that goes to a therapist who tells you what your dream means. Because shouldn't you be the one figuring out what your dream means? So rather than like looking it up on the internet, oh, I had a dream that I was being chased by, you know, a man in a hood with a knife, and I had to climb through this window, and you get online and you look up what that means. Well, they're going to come up with some kind of cliche type response, and there's psychologists out there that are in that business, but maybe we should talk about what's going on in your life today. What's causing, are you feeling anxious about something? Were you late for something? You know, and ask very few kind of questions to then get the person to talk, and the person will probably be able to analyze their own dream or gain their own self-insight through it, rather than suggestibility, because remember, your memories are highly suggestible, right? So we've got to be careful of that. But Freud wanted to be pretty literal in his dream analysis. And then he also cautioned that as these things are coming to the surface and the person is resisting the painful memories or that anxiety that they're facing, they may transfer their feelings onto the therapist. So maybe they come to realize that they're having issues with their father, and they have this broken relationship with their father, and so then they're getting angry, and they'll take their anger out on the therapist and yell at the therapist. So Freud, that was another reason why he didn't want to be like sitting face to face with his patient. He also tended to think that his female patients would mistakenly fall in love with him, which I always think is really funny. You know, and you'll see things in the movies or, you know, about patients mistakenly falling in love with their therapist because they're transferring whatever stuff is going on in their real life, and then they'll mistake the therapist's, you know, being there and being supportive and caring as, you know, this like relationship that we're really going to engage in. So it's not altogether out there, you know, some of these ideas, but the way contemporary psychoanalysis is done today should be more of a collaborative process, not, you know, the therapist telling the patient what's wrong with him and what it means, right? Yeah, tell me about your mother, and then I'll analyze it for you and tell you what that means. And, you know, I got my Freud safely tucked away in my office now, or I guess he's up on the shelf where he can't get down. He's up there. So psychoanalysis today is more of a short-term dynamic therapy rather than this drawn-out lifelong process that's got to be so painful. You know, you could go a few times. You could go just for, you know, every other week, maybe go 1 hour a week for a month, and the therapist says, you know, okay, you're doing well, you learn some coping strategies, you're coming to terms with your whatever it is that's going on, how to deal with your anxiety, and then you go every other week, and things are looking great, and he says, well, let's check in 6 months, check in, and then you maybe never see him again. Maybe you never go back to therapy again. And that's the goal, is that it's a collaborative effort to get you towards recovery so that you shouldn't become dependent on your therapist. I don't think any therapist wants their patients to need them, right? The whole goal is to coach and train the person to become more independent so that they can function and use the strategies out there in the real world, right? So it's a face-to-face, you know, back and forth, none of this laying down. A lot of therapists do have couches in their offices, but you know, it's a face-to-face collaborative effort. Okay, so humanistic therapy, like I said, we've got Carl Rogers, who founded the humanistic therapy. And again, humanistic psychology was that third force right along following after psychoanalysis with all the negativity of Freud, saying that these are people that are sick, in need of help, they're hysterical. He even has that as a term. You have hysteria. You know, like you're so like out of your mind that you have all these symptoms and you're in need of being cured. And so it was very negative. And then behaviorism was so sort of depersonalized that Carl Rogers said, first of all, these aren't patients in need of being cured. These are people that are coming to me for some advice, some guidance, some help, some expertise, and they're paying me money, or their insurance is paying me money, so they're clients. They're not patients. And so he called it client-centered therapy, or person-centered therapy is another term that he used there. And it's really based on active listening, and we'll get to that with the techniques of active listening, but his client-centered therapy is absolutely based on his theory of personality. And remember, his theory of personality was largely based off of Maslow, who said, you have to provide, all your basic needs in order to reach self-actualization, but we all have the self-actualizing tendency. We want to reach that pinnacle, but the only way to reach it, Rogers said, you have to give unconditional positive regard. And so in his personality theory, he was really talking about self-concept being established through the parents or the caregivers. So he takes really the same theory and now applies it towards therapy, now dealing with clients. I'm going to create conditions that show that I'm non-judgmental. I'm not saying, okay, you have to act this way or be this way in order to, get my approval. I'm going to create this collaborative environment. And it's going to be a growth-promoting environment. And the way I'm going to show you that I'm doing that is I'm going to use this active listening technique. So by doing the active listening, you're showing that you have empathy. You're reflecting. You're showing you're a good listener. You echo and restate what the person is saying to you. You're showing empathy. You're doing an activity where you're going through and the computer will kind of copy what you say. And you got to remember it's a computer, so it's, it's not a human. Humans are better, right, than computers when it comes to this type of thing. But someone who's engaged in active listening, by echoing and restating what the person says, and if you restate it in the exact same way that they say it, not only does that show that you're listening, you're checking for understanding at the same time. So maybe you repeat it back, and then the client says, no, that's not what I said. You could say, well, actually, yes, it is exactly what you said, because I just repeated it. And so I'm just checking, I'm clarifying, is that what you mean? Then the client might say, oh, well, actually, that's not what I mean. And it gives them a chance to reflect on their own words and possibly restate if needed. But that's where you get this sort of back and forth clarifying and checking. I think it also, by restating, you are validating that person by saying, okay, this isn't like a silly thing to say or a dumb thing to say. You're validating it, and then also they hear it, and if it's irrational, and then they hear their therapist say it, they're like, wow, that sounds really irrational. And maybe they can move forward in the therapeutic process. I try as best I can to do this in class when students raise their hand and ask a question or make a comment. I will try to echo what you said, both so that the whole class can hear it, but also to check for my own understanding. I try not to paraphrase what you've said, or I'll ask you, I'll say, can I paraphrase that? I've done that to you before, right? I said, can I say that in my own words to check myself? But the reason I do that is because I don't want students to feel belittled, like your words aren't good and mine are better, type of feeling. And so same thing in the therapeutic environment. If the therapist starts paraphrasing, then the patient might think that they aren't good enough or smart enough, or that their words weren't enough. So I think that all of it creates that growth-promoting environment. And Carl Rogers' therapy then really spurred group therapy, because not only could he do this on the one-on-one, he could also then, in the group, teach those skills to the members of the group in how you listen to each other and clarify for people's feelings. And they'll use this in family therapy. Sometimes families need to be taught how to communicate, mostly how to listen, right? That's a big part of a dysfunctional family, is people aren't listening. So Rogers would go in and he wouldn't say much at all. He's really, established some rules. This is how we speak to each other. This is how we question. This is how we allow someone to clarify. And then he'd kind of be just a mediator and kind of sit back and let everybody else do the work. Have you ever watched the show Intervention on A&E? So there's several different therapists on that show. There's one guy in particular who I think is pretty good because he doesn't suggest things to the family members. He lets them work it out on their own, and he kind of stays out of it. He establishes real clear rules, though, about, like, if someone's interrupting, he'll say, you need to wait and let her finish. She's reading her letter, or whatever they're doing, right? Let's watch this short clip of Rogers talking. He died in 1980, so I think it's kind of neat. It's like a living memorial of this person who had such a huge contribution on psychology and on therapy, and to see him kind of, see him when he was alive talk about this process. Okay, so then we have behavioral therapies. We have an unwanted behavior or something that's causing dysfunction, and we need to change that. We need to use learning principles to unlearn the negative behavior or this dysfunctional behavior that's going on, otherwise known as behavior modification. So we use behavioral therapies in children all the time. So based on principles of either classical conditioning or operant conditioning or a combination, you are using things to shape their behavior, change these unwanted behaviors. So we have different types. Counter conditioning. Now I'll go through these one at a time. So counter conditioning is based off the principles of classical conditioning. Exposure therapy, this is used for people that are dealing with phobias. At some point, if you really want to get over a phobia, the only way is to be exposed to whatever that thing that's triggering the fear. You have to face it. Aversive conditioning, based on the principles of classical conditioning. Now, instead of having some kind of association that's encouraging you to continue the behavior, you pair the unwanted behavior with something unpleasant. And hopefully you'll create this negative association in your mind then, and you'll stop the behavior. This is occasionally used in something like for drug addiction or alcoholics. And so they will pair the taste and smell of alcohol with something that makes you sick, like some kind of nausea-inducing drug. And create this connection in your brain, and you go, ooh, alcohol, gross. And so then you are turned off by it, and you don't want it. The problem is it's pretty short-lived. It might work at first in the treatment center, but if you haven't really done the real work, the real therapy, you know that you're not going to get that drug going down to the liquor store. You know that your Jim Beam isn't spiked, right? It's just nothing but alcohol. So people can reverse the effects of aversive conditioning pretty quickly. So it has limited success. Operant conditioning has much better success because this is, based on rewards, right? Rewarding behavior. Okay, so let's take a closer look at counter conditioning. Remember John B. Watson and little Albert? He and his assistant Rosalie Rayner scared little Albert with the loud sound, and he made a negative association of phobia, fear response to all fuzzy things, right? Started with the rat and then generalized it to the rabbit and then the fur coat, and classical conditioning was at work. Well, Mary Cover Jones was also a graduate assistant at Johns Hopkins at that same time, but she immediately recognized this as being unethical. And rather than completely just ditching the project, she said, we need to do something about what you just did to these children. They all now have phobias. We need to reverse the fear. And so her main subject was this 3-year-old Peter. And now instead of pairing the rabbit with a scary sound, every time the rabbit was presented, she'd pair it with his favorite snack. So we're still using principles of classical conditioning. And it wasn't, it's not operant conditioning because they gave it every time. So even if he was crying, if operant conditioning, you'd only reward the behavior you want to see. So you wouldn't give a snack with crying because you don't want to see crying, right? The reason why it's classical conditioning is because they just associated the rabbit with the snack. So every single time he got the snack. And they started out slow. So the rabbit's in a cage at a distance. And Peter's in his high chair, kind of up, away, safe. Bring in the rabbit in the cage, give Peter his favorite snack. Then they slowly move the cage closer, all the time making that association. Then eventually they take the rabbit out of the cage. Then they used some observational learning. They brought in other children who weren't afraid of the rabbit, playing with the rabbit and petting it. All the time reinforcing. So the little observational learning and operant conditioning probably at play in there. But by the end of 2 months, Peter has the rabbit in his lap. He's eating a snack. Phobia reversed. So she's counter conditioning. Mary Cover Jones was the first behavioral therapist. You know, so you take those same things, those same principles, and apply them out in the real world, create new associations in your mind to get rid of to not trigger the unwanted behaviors or the unwanted reaction. Now, Joseph Wolpe, reading about this stuff and classical conditioning, and he said, well, you know what you're really doing is you're actually doing an exposure. You know, she exposed the fearful thing to Peter, and bit by bit, he got over it. His anxiety was reduced. He lost the association, and it became a positive association. So Wolpe said, well, part of the problem is we need to retrain the nervous system. So this is a therapy that was really used for people who are dealing with anxiety. Generalized anxiety as well as specific phobias. So if you have a specific phobia and you know what it is that's triggering these feelings of anxiety, then that works really well because you can create an anxiety hierarchy. So let's say your phobia is of going to the dentist, and you haven't been to the dentist for several years, and now you got like a toothache and you know you need to go. Just the thought of going to the dentist and sitting in that chair, you know, with your mouth open and stuff is so anxiety provoking. That's what's kept you from even making an appointment. So first of all, Wolpe would say, well, we first need to teach you how to relax. We need to retrain your body, teach your body how to relax. And so this is called progressive relaxation. And a lot of you maybe have done progressive relaxation and not even really realized you've done it in a yoga class. At the end of yoga, you do the shavasana, right? And, oh, isn't that the best part? The best part of the whole class, because you get to just lay there and relax. But sometimes, depending on the instructor and how how meditative they like to get, they'll go through the muscle groups and have you think about relaxing your toes and then relaxing your knees, and you kind of go through all parts of your body. I took a Pilates class several years ago where she went through all the chakras, and there's different lights associated with the chakras. If you know anything about like Eastern medicine, Eastern religion, they have different sort of views on energy, and so she had you imagine the ball of light changing colors as it moved up your body through your core, and as you went through that, you would relax your body. But you could do it just sitting in the office with the therapist and basically training your nervous system how to feel relaxed. And we start to realize where we hold our tension. So some people will hold their tension back here in their lower back. A lot of people hold their tension up here in their shoulders. And so you go through the progressive relaxation exercise and you get up to your shoulders and you're like, oh my gosh, I can't believe how much tension I was just holding in my neck and shoulders. Other people will hold it in their jaw, and they don't even realize that their jaw is clenched. You're going to get an inflamed TMJ if you do that, right? So then you realize you got to, oh my gosh, look at all that tension that just got released. Or in your temples. Some people hold it there, or even in your forehead, right? Try not to hold too much tension in your forehead. You'll get a bunch of wrinkles in your forehead. So you're learning how to relax, and the whole time you're learning this, you then pair it with a control scene, which I like to call your happy place. So as you go to your happy place, you create all sensations that are associated with that happy place. So this is a great picture because that's really my feet. So I can really imagine that day on the beach in Maui and we went in December, so we'd been, cold, gray, all fall, and then, we get to go to Maui, and, that first day on the beach, and so I'm smelling the sea air. I can hear the lap of the waves. I can feel the sun on my face, and I'm just totally relaxed. So as I'm going through my progressive relaxation, I'm pairing my control scene with how my body is feeling, so completely relaxed. And it's the sounds, the sights, every sensation that goes along with it. So that's like a really important part of prepping for dealing with your anxiety. Then you come up with an anxiety hierarchy from 0 to 100. So if it's back to going to the dentist, 0 being no anxiety. Never going to the dentist, ever, 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 don't have to think about it, okay? To 100 being, like in the dentist chair with the drill in your mouth. That's like the highest it can go. So the therapist, or Joseph Wolpe here, would say we've got to have steps to figure out how to rank it. So a 10 could be making the appointment. You can do it, but it's a little, just the thought is getting a little anxious. Maybe a 20 or a 25 the morning of the appointment. Maybe walking into the doctor's office or the dental office, a 50. So you rank it. And the goal then is every time you start to feel that anxiety climb, you go back to your control scene and teach your body how to relax and not let your negative, irrational thinking spiral your nervous system. Because everybody's going to feel some trepidation going, maybe going to the dentist. I know I do a little bit. It's not exactly fun. So, although I know some people like getting their teeth cleaned because they like the way it feels afterwards. But there's a little bit of, I don't really want to be here doing, it's kind of uncomfortable. So, but letting people know that a certain degree of anxiety, that's normal. Right? It's normal, but then how are we getting back down so that you don't have it escalate? We're going to watch this video of a guy that has a fear of elevators and how it's a little too much to do his systematic desensitization right away in an elevator, but he can do it wearing a virtual reality helmet and a simulated elevator. So this is kind of neat to watch. Okay, then we have operant conditioning. So operant conditioning, remember that was Thorndike and B.F. Skinner. But when we're looking at changing an unwanted behavior, we can really use the token economy, meaning that we're pretty much using positive reinforcement. So every time you see a behavior that's desirable, you give a reward, you give a token, right? And it could really be a token. It could really be something that they're earning that then they use as chips to buy something. So this could be in a case of like a rehab center where you're earning tokens that can then buy you things or earn you privileges. Like you get to now go to the movies, or you get to, buy certain things from the store and whatnot. When we're talking about behavior modification in children, usually it's earning some kind of rewards that you gather up towards some end goal at the end of the week that could be a privilege, like going out to dinner or something like that. A lot of classroom teachers run their elementary school classroom on a token economy, and they have some kind of behavior management system or classroom management system, generally the thought is that you should always be rewarding the behaviors you want to see, and then when you see behaviors you don't want to see, you have to be careful about, okay, what's the contingencies? Are we punishing or are we taking things away? There's a lot of different ways you can do it. Typically, we don't want to punish the undesirable behaviors. Rather, you just give no reaction. But I suppose it depends on what the person's disorder is or what it is that you're dealing with. If it's a child with autism and you're trying to create sociably desirable behaviors like answering questions or eye contact and not hitting or grunting or whatever it is that maybe you don't want to see happen. Back in the 70s and earlier, before they knew as much as they do today about autism, they would use some of these principles of operant conditioning, but they would do things like punishments. So if the child did something undesirable, they would slap their hand. Okay, therapists don't do that anymore, although you can find probably anything and everything on YouTube if you look. But now, rather, when you see the desirable behavior, they get some kind of immediate reinforcer. And if they don't do the behavior you want, you just give no reaction. And then you give the prompt again, and then hopefully they'll get it right, and then you can give the immediate reinforcer. So I watched this video of a child with autism that was doing some kind of task. He was matching colors or numbers or something like that, and so the therapist was sitting across the table from him, asking him to match something, and as soon as he got it right, she gave him this ball that flashed. So it was a white ball, but when you hit it on the table, it would start flashing and blinking. And it only would blink for about 15 seconds. So she would, as soon as he got the answer right, she'd give it to him, and then he'd hold it up to his eye. And he really liked it, because a lot of people with autism like stimming. They like those sensations, and so he'd do like this. Okay, and then it stops blinking after about 15 seconds, and he had learned that he would then set it back down on the table, and she would take it back. And then she gives him another prompt, and he got the answer wrong, or he yelped or something, or did something that she didn't want to see, so she had the ball right in front of her, and she just sat unresponsive, no punishment, just unresponsive. And then she gave the prompt again, and then he gave the right answer, and she immediately hands the ball and doing this again with the ball, because that's what he wants and what he likes. That's probably that's an indirect reinforcer. A better reinforcer is if it's absolutely matching the skill, but we try to stay away from giving tangible things like food, giving treats to kids all the time for every desirable behavior you see. Sometimes I know I've done sticker books for kids and a prize box at the end of the week when you have some kind of behavioral thing going on in your program. Okay, so cognitive therapy now. Now we're not talking about changing unwanted behaviors or dysfunctional behaviors. We're talking about fixing the thinking. So the underlying assumption is that it's your maladaptive thinking or your irrational thinking that's then creating the dysfunction. So it's intervening, it's getting in the way, and then it's creating this emotional reaction that's either exaggerated, over the top, and that could manifest in anxiety, or it could manifest in depression. It sort of depends on what's going on with the person. Now, Aaron Beck came up with a type of cognitive therapy that he used for severely depressed patients. And he was very confrontative in his style. So in his questioning and getting the person to talk, unlike Rogers, Rogers would still, his therapeutic process would still be to challenge. Remember, he said, if I found myself not liking my client, then I'm going to tell him, I don't like your behavior, right? Still unconditional positive regard. I don't like your behavior, not I don't like you, but what you're doing is offensive or abusive or whatever. You pinpoint that. Beck wouldn't be so much in the feeling part of it, but more let's tackle what you just said and confront what you just said, and where is that thought coming from, and is it a rational thought? So remember our little diagram of the breakup? So we've got, you got dumped, and if you use, if your explanatory style is more optimistic, and you don't see it as this life-threatening, like end-all. It's not so stable. It's more malleable. You have external explanations. You kind of realize that it takes two to make a relationship work. You understand, oh, thank goodness I have other friends and I have family that support me, and I'll find the right person. That wasn't the right fit, and that's how you lead to successful coping. Same event happens to someone else. They use these internal, stable, descriptors for why this happened to me. This is the end of the world. He was my soulmate. I'll never find anybody better. No one else will ever love me. How am I going to move on? I can't live without him. And you could see how that pathway is going to lead towards depression. So Beck would challenge every single one of those statements that I just said. He'd say, so no one will ever love you? So your ex, he's all-knowing? He's an all-knowing being? Or how do you know that? Okay, so he's challenging the irrational thinking, but he's not doing it in a sarcastic way. You got to YouTube him as well. Big bow tie, Aaron Beck. And he says it in a very logical, so do you have any other friends? Oh, well, sure, I have friends, but those are friends that, not in love with them. I said, well, you have people to support you? And so he's challenging. So every step of the way, every statement, and then hopefully what will happen is the person will start to realize how exaggerated this thinking is. I mean, it's really, is it really that? Is it the absolute end of the world that this happened? Sure, it's devastating, but he's trying to get them to realize how exaggerated these negative thoughts are. And once you recognize that, then you can start moving forward and go, oh, well, I do have friends. Oh, okay, I do have support. And you start to realize that there's something, other possibilities, other options out there. And in some of the interviews, if you do go on YouTube and look for them, he'll get the person laughing. And they'll even, like, if they record the session and then they watch their old session, they're like, wow, I can't believe how irrational that thinking was. Think about your own life. Think about, 5 years ago, something traumatic happened to you, and you're like, wow, I can't believe how, immature and irrational that thinking was. And part of it could be immaturity, but also part of it could be is if you're suffering from depression, your frontal lobe isn't firing. So you're not thinking rationally. So a confrontative style of therapy, okay? It might not be the best fit for everyone, right? You might want somebody to hold your hand a little bit more. So then you go to someone more like Rogers or from that sort of framework. So the same event, some people take it as this internal, stable, consistent thing, and that can turn into depression. A different person takes it as an opportunity. So you can teach someone how to change their thinking. Some people are, just much less likely to suffer from depression because they naturally do this. You're kind of like the glass is half full type of thinker. And so you're probably less at risk to suffer from depression, but you never really know. I mean, if something traumatic happens in your life, you're just not really sure how you're going to react. And people aren't always the best judges of themselves. I like to think we know ourselves, but we don't really know ourselves that well until it happens. And then there's lots of combinations of the different approaches, and we kind of put it in this big category of cognitive behavioral therapy. So we got to change the negative self-defeating thinking, but then at the same time correct the behavior. So cognitive behavioral therapy is often going to be used in a lot of the different anxiety disorders, because anxiety has some different components to it. There's the thought process component that's causing problems for you, but then your behaviors might be either an unwanted behavior like acting out a compulsion, if we're talking about OCD, or not leaving your house, if we're talking about something like agoraphobia. So that's a behavior that you have to change. And we're almost out of time, so we'll watch this video first thing at our next class, and then this is the mother with OCD, and we'll watch her go through a therapy session, just like for 5 minutes, a clip of her session, and I want you to pay attention to all the things that the therapist is saying to her.